Welcome back to Innovate and Elevate. I'm Sharon Kedar, your host. Welcome my good friend and my personal doctor, Dr. Rachel Rubin, to the podcast. We've been working together for a couple of years now. I'm 51 and I take 5 different medicines, which we will unpack in today's episode. Let's talk about how we got here and how we're really going to fix this menopause care crisis. First, just a quick background on Dr. Rachel Rubin. She is a board-certified urologist and a fellowship-trained expert in sexual medicine. She's an assistant clinical professor at Georgetown University, and she's dedicated her career to providing comprehensive care for people of all genders. So let's dive into this conversation. I have my good friend and my personal doctor, Rachel Rubin, on the podcast today. Hi, Rachel.
Hi, I'm so glad we finally got around to doing this.
I like your necklace.
Thank you.
Do you think people actually knew what you were wearing, your necklace on Peter Attia?
I think some of the women did. I think probably 5% of the women who saw it knew what it was, and 95% of all humans had no clue.
Wait, that's what's so awesome about you is you are blazing the freaking trail. Like you are redefining, in my opinion, what it means, not just like women midlife, but dare I say to be a woman.
That's very nice of you to say. I think the reality is I try to talk about sex like it's high blood pressure and diabetes and really bring it back to biology and physiology and how the body works.
I want to take the listener and viewer into the doctor's appointment with you. So you've been my doctor for a couple years. I'm 51. And I just think most people don't get to have this appointment with you. I brought my husband, Greg, who I've been with for 30 years, to see you last month, to see you at the first appointment. I think it is so much more than sex. And I'm just going to go on record. You're redefining what it is to be a woman, because I think women are basically like discarded at midlife almost. And it's like we birthed the whole population. So can we talk about midlife, and can we talk about what a midlife appointment looks like with you? I think you're just so natural at it that you just think it's like normal. But before we do you think it's more than sex?
It's a lot more than sex. It's funny, as a urologist, right? I was raised being a urologist, so I take care of men. I take care of men's quality of life, all sorts of things. I never thought I would treat so much joint pain, so much brain fog, so many sleep problems. Yes, so many bladder and sexual health issues, which I was trained to do. But because when we look at the whole picture and the whole person, you find that there are so many areas screaming at this time period about when there is a change in hormones. And so you have hormone receptors throughout your whole body, and they don't teach us in medicine. We're very siloed. The gynecologist focuses on your reproductive organs. The cardiologist focuses on your heart, right? Like, it's very few people are looking at the whole picture. And there's many reasons why they've ignored HRT for so long, as you can see from Sharon's button there.
HRT being hormone replacement therapy, for anyone who's new to this, which is basically something that all women's hormones, as Tamsin said at her party for Vonda, run out the door at a certain age. They don't walk, they run. But
yeah, no, I think, right, there is in your 30s and 40s, the best way to describe it, I think it's so beautiful, is NFLM, not feeling like myself. And so really, when people come to see me, I really let them tell me their story.
That's what's so amazing. So I know that you can't just sign up for an appointment with you practically for a lot of reasons. By the time I got to you, I had seen 5 doctors. Nobody had told me that basically I would have a baby at 40 who was my third, and then in that same third C-section basically have my tubes tied, which was my choice, but effectively enter into perimenopause. Nobody explained the concept. You'd think I'd know because both my siblings are doctors. I'm the only non-doctor, but I think you hear this story all the time. But I think the biggest part of the care crisis, and then we'll walk into your office, is that no one tells us. So how do we even know that this is happening? Does anyone ever walk into your office actually ahead of this yet? Maybe our daughters will, but is everyone like a hot mess like when I walked in? And I don't want to minimize myself and describe that way, but I wasn't sleeping. I had brain fog. It was like, help me, Rachel. At that point, it was Dr. Rubin, and then we quickly became friends.
Can I tell you, I am hopeful, actually. I had a neighbor who texted me last week and said, I started having bad sleep and I had my first hot flash and I am quickly patched. I just got my first patch and I never would have done this so quickly if it hadn't been for your social media and me following what you're doing. She's not my patient. She found a different clinician to help her, but I'm really hopeful because she didn't suffer. Whereas
Wow.
I saw someone else who was a family friend who I see at family functions who basically didn't come see me till she was 53. And I'm not quiet or shy about what I do. She knew who I was and what I do for years and years. She said, what the hell have I been doing for 10 years? And basically told her family members who are younger than her, don't wait. You don't have to feel this way. So I think what you're doing is so important and revolutionary. And I don't want to minimize the importance of people who are bringing awareness to this topic. The more you realize that NFLM, not feeling like myself, is a diagnosis in and of itself of, is your sleep different? Is your mood different? Is your sexual health different? Are you feeling hot? Is your temperature different? Are you getting hot flashes, night sweats, heart palpitations, aches and pains? The joint pain is a huge one that we have dismissed. So we're not making this up. It's not new. It's just that we didn't have language around it. And I think what's beautiful is now there's a lot more awareness and language that we're putting towards a problem that has been around for our mothers and their mothers before them.
I'm just going to go on record saying that I think you're a women's dignity doctor. I think about women like my mom, who you know, because of you, she's 77 and she was pulled off of her estrogen 20 years ago. And she hasn't slept in 20 years. I literally have chills. But these conversations, they don't even come up. Someone just today offered her an estrogen ring. She's got some additional issues. But I asked her, I'm like, why? And I guess it's like, why did you settle for where you were? And I guess that's like a big question I have. If I'm defining you as a women's dignity doctor, which by the way, I think is super pro families. I think that any partner, any husband is so much happier when, you know, their midlife woman is on the right treatment. But why did we get it so wrong? And I know that Peter called it the greatest medical indignity of our time. I didn't tell you I was showing up at the FDA, but I wanted to support you that July day. You forever will be in my head about that. But why did we get it so wrong and how do we fix it? And then I'd love to save time to just go through like a doctor's appointment with you.
Yeah, I think there's a lot of reasons, and we could write books and books about how all the different ways we've gotten it wrong and why it's so wrong. And I think we often lack a humility in medicine to say, hey, we got it wrong and we need to do better. Sometimes we do the best that we can with the background that we have and the information that we have. The field of OBGYN, we expect those brilliant, amazing, wonderful humans who have no resources, who are expected to take care of half the population. I'm a urologist, right? I'm a men's health doctor. No man comes to me for his heart, for his lungs, for his brain, for his breast exam. No man comes to me for everything. And we expect the idea that a 10-minute visit with your legs up in stirrups once a year is adequate healthcare for a woman. We ask OBGYNs to be emergency room doctors, to be surgeons, to be baby doctors, to be pregnant people doctors. We ask them to do primary care. We ask them to do too much with no resources, with higher malpractice costs, with no extra training, with no support, and the rest of the medical community saying, women, that's an OBGYN issue, go to your GYN. It is unconscionable what we're doing. Every doctor should know how to take care of women, actually. We should do a better job of training all the doctors to understand women's health and not just through the lens of this was studied in men. And the problem is it just takes time. We need more women in high research positions and high places of power and with funding. It is changing because of people like you and your friends and people who are saying, hey, we need more research in this and awareness.
Well, but there's just so much to unpack there. So when you said this was studied in men, basically this idea that medicine, I just think it's helpful for people to know doctors mean well, but the history is that the system was trained on a 75 kilogram man. And so we can look back at all of the history going forward. I think that the reason I'm involved is I just want people to know. It's like I went to 5 different doctors, was prescribed the wrong medicines. I just want women and their families to know that they're going to have to advocate for their care. How do we fix this care crisis? I can imagine that we enhance medical school curriculums. You're doing amazing work with your class, which I'd love to unpack. But how do we get women like my 77-year-old mom to know to ask? She was like, I didn't even know I need to ask. And it's like suddenly she's got an estrogen ring, which she only has to replace every three months. And I know that the whole vaginal estrogen conversation is going to take 17 years to go from the new protocol to doctor's offices. So what do we do?
I actually think you are uniquely able to put your brain on this and help us, because I think actually a little bit we have a marketing problem. Like we actually have a marketing problem that is fixable. I always talk about we're at a battle on many fronts. We are battling the status quo in that we are not using the tools that we have and have had for decades. We're not using them appropriately. You weren't offered the tools that we do have. We have the unknown, right? The things that need to still be figured out, the research that has to happen. We have the battle against the snake oil, the people who are trying to take advantage of women and families that spend money on things that don't actually work and have no evidence or science behind them. That's why we went to the FDA, because when your mom gets her estrogen ring, there is a label, a big box label on it that says it's going to cause a stroke, heart attack, blood clots, probable dementia. None of that is true.
I don't even think people realize the 20 years of misinformation that happened from the false information from the 2002 government-funded Women's Health Initiative until the Menopause Society in 2022 updated guidelines, which is like 20 years. But you're saying that now the misinformation has been updated, but
there's still a marketing problem because it's not getting to the people who need to hear it. And so we have a marketing problem of getting people to know why it's important, how to do it, how to change it. And then really for me, it's how to write the prescriptions, because the challenge is in who is responsible for writing these prescriptions, because it should be primary care doctors. It should be cardiologists or orthopedic surgeons. Like people are dying of fractures. They have a horrible osteoporosis. They get urinary tract infections after their joint replacements. They can't exercise because their muscles have atrophied. So they are the most important doctors to talk about estrogen and testosterone.
Wait, that's why I think it's women's dignity. Like I think we're literally talking about the dignity. I did a post last year for season 1 that talked about how breast cancer doesn't care about your political party. This just has to do with like, no matter who you are, your own personal dignity. But when you say that there's a marketing problem, and it's funny because someone asked me to be on a marketing podcast for the health of women. I was like, I'm not a marketer. Like I'm a venture capitalist, I'm an investor, I'm an innovator, but I'm like, marketing.
I didn't mean it from the venture capital, but from the Harvard Business School approach, right? This idea of from a business perspective, how do you sell a product? How do you get popularity? How do you sell an idea to someone? Yeah. You are uniquely qualified to help us get out of our own way, because I think right now we're not getting out of our own way, and we need big thinkers like you and others who can, and this is why, right, when the Melinda Gates comes out and says she's going to fund hundreds of millions of dollars worth of research, the challenge is that doesn't get us anywhere because these researchers and scientists and doctors don't know how to message and market and really get to the important issues.
To your point, there is a cycle that needs to be broken, and that was talked about a bit last season. And some things surprised me last season with the health of women. I didn't think it should be too surprising to the world that mice don't menstruate. And when that was said to me by Don Ingber, and it surprised the world because mice are the bedrock of research today, basically that effectively means women are human lab experiments. But the part that I think the marketing problem right now, and I haven't unpacked this enough to understand it, the part that I think is the biggest marketing problem is 1 in 8 women will get breast cancer, and the fears from 2002 about breast cancer. I don't know enough to talk about that, but when I really have private conversations with people, to me, and I don't know if that's what you hear, to me, that's the thing that scares people the most.
I think the reality is not every breast cancer is the same thing, and not every patient is the same risk factors. and actually this blanket, like you can't have this, we have to move past that because it's dignity. Everyone's going to die. You and I are both going to die. And the question is, how are we going to live and what dignity? Because my grandma, God bless her soul, had dementia and osteoporosis and lived a floor apart from my grandfather who broke her ribs just giving her a hug, and she didn't know who he was. I don't want to live to 93 and be that way, right? If I'm going to live till 72 but be able to live a life of purpose and strength, that's what I choose.
Wait, the train has left the station on the call for dignity. Like, my mom said that I could say this, and my sister laughs when I say this, but when you think about women's dignity, my mom is finally getting the treatment she needs, but she has an issue that she didn't even tell me. It's like women just suffer, and it's a condition called lichen sclerosis in her vagina. Where's the dignity to level up? I want to go through, because it was actually really hard for me to get on my own HRT, reclaim my dignity, learn that I do deserve to sleep again as I turned 50. And it was like the lights went out when I suddenly wasn't sleeping. But before we go there, can we just talk a little bit about, so what you're saying is you think it's effectively all doctors. And I do agree, because I think menopause can and should be, whatever we want to call it, women's midlife, a specialty, but that will take years. I was trying to think of the last time a specialty emerged. I think like family medicine emerged in the 60s. Neuroscience emerged in a field around the same time. That's not a medical specialty, but there is precedent for, but it takes a long time, medicine to emerge and for new specialties to emerge. But like until then, we need GPs, general practitioners, we need OBGYNs, which, okay, maybe it's 20 different fields, but it's at least the childbirthing years and the following years is separate, where women deserve a conversation. And I think my big message to people right now is, I do love doctors. I want to get another pin that says I love doctors. They weren't trained on this for whatever the reason. Keep going to doctors till you get to the right one. But can you just talk about your course and how you came up with it and like how you think that'll fill things, but also where should someone go? I do think it's a care crisis. So I asked you a lot, answer it however you want, and just thank you for being part of the answer.
The care crisis is so overwhelming and so all-consuming that my way out of it is through action, is how can we take as much action as we can to move steps forward. So what I've chosen to do is focus on research, advocacy, education, and mentorship. I really try to live my life with those goals in mind. And so one of the things is I try to take action wherever I can. So I see the patient one-on-one in the exam room. We're going to talk loudly about your case publicly, which will help so many people be, and I love this idea of being able to do that. But then it really came to me as how I do a lot of courses. I teach for Harvard, I teach for all these people where I go and I try to teach. And one of the ways that I try to teach is I put prescription pads on the big slides and I say, this is how I write the prescription. It's the way I've learned to teach. And everybody kept saying, oh, your lectures, they're so funny, they're so interesting, they're so helpful. And so I had actually a friend who said, okay, where's the course? Where's the course? We put together a very short course with continuing medical education that teaches doctors how to write the 5 common types of prescriptions in menopause care. It's about a 5-hour course. It's not that long. There are modules that we've made that are 20-ish minutes so that you can do it on a commute, that you can just listen to me and I'm hilarious. But it's a really very basic of why did we get to where we are? How do we talk about the Women's Health Initiative? I teach through the concept of what are you afraid of? And so when a doctor says, can I do this in a 52-year-old woman with a history of high blood pressure? My answer back is, what are you afraid of? If they say stroke, there's no increased risk of stroke when we use transdermal hormones in this patient population, and I show the data. And so we teach them what they think they're afraid of, and then we match it with data to say you shouldn't be afraid of this for these reasons. Then at the end of it, it's for basic prescribing of hormone therapy. Again, the very complex cases, the complex pelvic pain cases, the complex sexual medicine patients, send them to a specialist like me or one of my colleagues, where you can find them through ISWSH, ISSWSH.org is a way to find sexual medicine providers. But the reality is basic menopause care should be, anybody can and should be doing it. So this course, we go over the 5 common things that we have to care about. And that's what we can talk about your prescriptions and what you chose out of the toolbox. So the 5 modules of this course are whole body estrogen, or what we call systemic estrogen, and that could be a patch, a gel, a ring, or a pill, right? There are a whole body progesterone, which means if you have a uterus, you have to protect it with progesterone, but it also helps you with sleep and anxiety reduction in most people, not everybody. So estrogen, progesterone, testosterone, which helps with libido. And all of my patients say it helps with so much more than just libido. But we go over into the evidence-based reasons of how and why to prescribe testosterone, which is life-saving and wonderful for many people. Vaginal hormones, which is the most important thing for your 98-year-old grandmother in the nursing home or your perimenopausal patient, because it will prevent urinary tract infections, will make sex not painful, will help with lubrication, arousal, orgasm, will also help with frequency and urgency and getting up in the middle of the night to pee. And the fifth one, and that's the most, I would say, nuanced and expert level thing that we sometimes talk about, is the area at the opening of the vulva called the vulvar vestibule, which requires some hormones, both estrogen and testosterone, to help with pain with intercourse. And so that's an extra bonus module. We do have a module on libido where we talk about some libido drugs, non-hormonal options, and things like that. We teach people in this course how to do exams, how to talk to patients. We go over the data and we give the papers of why this is so important. And we've had hundreds and hundreds of doctors now take this course, and clinicians. We've got nurse practitioners and PAs. But for me, it's the start of like, how can we make sure the prescriptions are getting written? So that's a big overview, but let's talk about what you've chosen.
Let's talk about, for anyone who's listening who is a doctor, because I do have a lot of doctor friends, where can they take the course?
Yeah, so it's on our website, rachelrubinmd.com, under the education page. You can find it on all my social media. It's online, so it's just a course platform that we've used, and you can get some continuing medical education credits. The nice thing about it is you don't have to show up. You do it at your own pace. So it was really beautiful. On my birthday, actually, it was last weekend, and someone posted on Instagram that they were sitting there with coffee on a Sunday morning taking my course. And I was like, that is the best birthday present in the world, knowing that I was not teaching and on my birthday, thank goodness, my husband would have killed me. I was not teaching on my birthday, but that someone was learning how to do this. It just gives me chills to think about. Again, people are talking about it because people, as you said earlier, which I think is so important, doctors care. They want to do the right thing. They want to help you. And they really are good people that are suffering right now. Also, doctors are really suffering right now. And the reality is no one taught them how to do this. They truly don't know how to do this. And so I'm trying to help them say, I get it. I get you don't know how to do this. Let me help you. And really, if I as a urologist can do this, you as a brilliant primary care doc, OBGYN, endocrinologist, you can do this. And the way I know that I'm onto something is that I spoke this last year at the American College of Physicians, which is the largest internal medicine conference in the country. There are 20,000 doctors. And I was asked to give a course on female sexual medicine, and I put a lot of menopause content in the course. And doctors, and I am one of them, never fill out evaluations. We do not do it. We do not fill out a commentary. And there were 275 people in the room, and I got 275 thank yous with comments about how it was like the best lecture they ever heard, how they learned so much. And the comments were just so incredible. I got a standing ovation at the end of my talk, which we don't do at medical conferences.
Yeah,
that's
as you
not
should,
a thing.
though, as you should.
But they're hungry. And the reality is no other content at the meeting was about menopause or women's health.
It's almost like, to your point, permission to dig deeper, just given some of the history and some of the fear. And just so we'll talk through actually those exact 5 areas.
You meet people where they are and you give them what they need. The first time we gave you things wasn't like, oh, everything's perfect and now everything's perfect. I think sometimes there are challenges. It is not a one size fits all. Not everyone needs the same thing, and not everyone needs all the things. The more you can learn about it, the more you can tinker and say, okay, now I'm really not sleeping. So now I really need to try this.
So I'll just start with where I am now, but I'll just say, and Rachel knows this, it was a 2-year journey, and this is a little bit embarrassing, but I was so overwhelmed. And this is where it can't be a 10-minute appointment, because as Dr. Rubin says, there's 5 areas, and that takes iteration. Every human body is different. Mice don't menstruate, so we don't have that history and that information, so we have to iterate through a patient. I iterated this protocol with Dr. Rubin and my holistic doctor together. I would not be here without this brilliant woman who never gave up on me. I actually initially got so overwhelmed that I just didn't do anything after spending all this time. I just felt overwhelmed. So I know this can be overwhelming, but
which is actually, just pause for a second. I want you to know how normal that is and actually doesn't scare me. It really is sometimes this wave of you dip a toe, you jump out, you dip a toe, you jump out. And I've had patients who try and then they stop everything and they'll come back a few months or even years later and say, oh, I thought that was perimenopause. Now I'm really in it and I'm ready to try again. And we're here. I always say my mission is to meet you where you are and give you what you need. Some patients need to take those breaks. You can't upset me. This is not about me and my ego. This is about you and what you need. And so some patients need a little tough love or a little bit of, hey, let's get through this together. Some patients need some hand holding. Some patients need time. It's really your doctor, and you have to create this team of what actually do you need. I will tell you, some of my happiest patients are the ones who came to me and said, Rubin, I will not take hormone therapy. I'll never do this. It's dangerous. And through really talking about the data and talking about it, meeting them where they were, they dipped a toe, decided to try it. And now they are evangelists and almost religious about telling everyone about hormone therapy. And they could be poster children on a billboard about hormone therapy. It's very funny. So education and meeting people where they are and going at their pace, because it's not a race. You got to run your own race here.
You do. And it's a personal story. First, so estrogen, this could be a title that estrogen is not a 4-letter word. Obviously, talk to your doctor. This is my medicine from Dr. Rubin, but this estrogen patch, it's a branded patch. It's the 0.075. It took me a while to work up to it. When we first talked about estrogen, this idea that you put, it looks like a Band-Aid, but it's something you put every 3.5 days on either, I guess, where the fatty part in the front or the back. I put it in the back near my hip. I don't know. Everyone on Instagram has it in the front. I'm not sure why, because it's called transdermal.
So we love estradiol, which is the natural form of estrogen, as opposed to a birth control pill style, more synthetic hormone. But that's okay too. That's actually a lot safer than we thought it was also. So there's no right or wrong answer, but many of us like transdermal, non-pill versions of estradiol, but it comes in many forms. So it's the same medicine, but it may come in a gel, it may come in a patch, it may come in a ring that goes in the vagina. There are pill versions of it as well. You could even inject it if you really wanted to. There's an FDA injection. So there are ways to give it to you, but it's the same stuff. It just is a different sort of way to give it to yourself. And there's no right or wrong answer. It's what works for you.
Okay. And just the concept, I'll just show everyone what it looks like. But the idea of getting on the right dose, this is what it looks like. And then it just goes on the front or the back. Actually, Rachel and I posted my patch a couple months ago with some
dirty,
dirt
grimy
around
stuff.
it.
It's the tiger stripes that everybody gets. So it has some buildup around it, which can get annoying. And some people don't like patches for that reason, and they go to a gel or they switch to something else. And the dose, right? So I actually think a lot of my colleagues who are nervous about hormone therapy, they go too low. Now, I like starting medium or low with people because you can get breast tenderness. And so I'm okay with starting low. I like this 0.05 dose at least to get to for people because I think it's enough to really get your hot flashes gone, to really help with the temperature issues. I'm a little bit more aggressive than many, but I think that's part of the issue because I think sometimes we go too low and you don't notice the benefits, so you think, oh, this doesn't work for me.
Also, some of the emerging data on the bone benefits, bone health and estrogen going too low is not helpful in that sense. So folks need to talk with their individual doctors, but I think this is tricky in the sense that, to me, it's like the foundation of the house, estrogen, when you're in perimenopause, menopause, and when you think about all the symptoms, brain fog, not sleeping, frozen shoulder, just all the things, to me, this is like the foundation. It can take a couple weeks. Is there anything else you want to say about estradiol before we get to the second?
If you go to a clinician and they have one option, one dose, one thing that they know how to do, they may not have the whole toolbox for you. If they say pellets are your only option, then they don't have the whole toolbox for you, and they may not really know the data and know what's going on. So as we teach people how to do this and people are learning, you want to see that ability to say, yeah, there's lots of options. You could do a patch, you could do a ring, you could do a gel. They know the pharmacies to send it to. They know the costs of it. They know how insurance covers it. So that's the goal, is to get your clinicians to have this language a little bit better. But yeah, I agree with you. Estrogen is the workhorse, I call it. It's good for your bones. It's good for your blood vessels, right? It gets your hot flashes gone. So it's often what we start with. Again, in perimenopause, it gets confusing because your ovaries go really high still, but they can drop really low. So that estrogen can be 900 one day and 20 the next day. And that hurts. That fluctuation can really hurt. So people work with that in different ways. And then if you have a uterus, it's really important that you balance your estrogen with what's called progesterone or a progestin. And we love natural progesterone, which I think is what Sharon's going to talk about next.
Yeah. And just on this too, like one thing that I love that Rachel and I did, because she knows me well enough now, is I'm one of those hypersensitive patients, unfortunately, or fortunately. It's probably why I'm doing the podcast. But when we went from 0.05 to 0.075, we cut, this is when you know you have a world-class doctor, we cut a 0.025 in half to help get me up because of some of my, and I don't like to identify as hypersensitive, but it's just the reality that I do better with gradual changes. So that was amazing, and I think we innovated that, and it's not that easy to cut a patch in half. But then the progesterone that I take is, there's the one that helps make everyone sleep. That one hurt my stomach. It's important to follow your doctor's orders, but I ended up doing compounded progesterone through talking to Rachel and my integrative doctor, and it was just like a game changer for me. It doesn't help me sleep. I don't know why it doesn't have the same sleep benefits as the over-the-counter one, but Rachel, let's not forget, for a while as you and I were innovating, the advice was to stick it up there in my vagina. But that was a hot mess, literally, because every morning I would wake up to a clump in my underwear. I cannot believe we're talking about this, but yes.
You're doing great. You can put pills in the vagina. That sometimes it can work and absorb in that way, and sometimes it works for people and sometimes it doesn't. So progesterone, basically, if we think of the estrogen grows things, your hair, skin, and nails, it can also grow the lining of your uterus. Progesterone is kind of like a lawnmower. It keeps the lining thin of the uterus so that you don't thicken up the uterine lining, which after many years could lead to uterine cancer. We don't want you to get uterine cancer. So the progesterone is good if you have a uterus. Now I have patients without a uterus who sometimes take it for sleep benefits. And the FDA-approved version of progesterone, for about, 80% of my patients, they do very well with it. It gives them good sleep. They're fine, but about 20% are extra sensitive. And it's okay. We come up with other workarounds. So some of the workarounds are using it vaginally. IUDs, like a Mirena IUD, could be a workaround. Some people use compounded products, though you don't want to use, I'm not a fan of topical products, so you don't really want to use a progesterone cream because we really don't have safety data on absorption from that. So you do want to be careful. And again, if you're bleeding like crazy or something's not right, well, you really do need a workup, and you need to see someone who knows what they're doing to make sure that everything is absorbing well and no overgrowth is happening.
And 100 is the starter dose. I know you can take 200, you can take 300.
This is an area where we wonky experts like to debate and talk about, and where we need more data. I think 100 is a great place. Sometimes I'll try to get patients up to 200, which can be helpful, especially if they're going higher on their estrogen dose. It's not very clear, but again, if you bleed like crazy or something's happening, it's a tell that either you need more progesterone or you need less estrogen, or that maybe you've grown a polyp or something like that. So
yeah, this speaks to why it's not a 10-minute doctor's appointment. But if someone's on 100 of progesterone, that's like the baseline, right?
That seems, yep. Yeah, I wouldn't go lower. We don't really agree with lower than that as a long-term plan.
I have so many just like stories of my journey, but when this was getting compounded, I got it through my alternative doctor, and they gave me sustained release. So when I was at the White House in December for that women's health event, I was on 300 of sustained release. Why am I so tired? And I was drinking so much coffee, but getting the compounded progesterone is not that easy. And then I think you actually have to say, so this is like when people ask my why, you have to actually have a sensitivity to the prescription one to be able to get it, and then you got to make sure it's immediate release.
The FDA approved option has peanut oil in it. So if you have a peanut allergy, you also want to get a compounded product.
Yeah, and for most people, it helps them sleep and doesn't hurt their stomach. Of course, for me, I was that like 1%. And then this is the testosterone from you. Ooh. So what do you want to say about testosterone?
Okay, so testosterone is not a feeling. It's also not a man thing. It's an everybody thing. We all have testosterone. We actually make a lot more testosterone in our body than we do estrogen. And testosterone actually starts to drop in your 30s. We find actually it's not menopause, but as you're in your 30s, you start to have, my libido's a little lower, my arousal, my orgasm are changing a little bit. I have more dryness. Maybe I got a urinary tract infection or a yeast infection a couple times in my late 30s. It's because the microbiome is changing. And if you put that on top of, I just had babies, where Sharon and I are in Washington, D.C., where everyone's having babies in your late 30s and your 40s, you're going straight into perimenopause and this androgen or testosterone drop. We have no FDA-approved testosterone for women. We have an approved testosterone in Australia, New Zealand, in Britain. And it doesn't make sense why there is not a product in the United States. So we have to use either male-dosed generic testosterone, which Sharon will tell you sometimes has a musty smell to it, versus sometimes you can get it compounded. So I use the FDA-approved version in my tubes, but Sharon likes this compounded. So we have options. We have tools of if one doesn't work for you, we switch to something else.
Okay, so there's so much to say about that. One is Kelly Casperson, we recorded an episode in her book, which talks about testosterone as the forgotten quarterback. I think testosterone, to your point, as you said, is just so much more than libido. It's about brain fog. It's about feeling strong. It's just so many different things. And that's why HRT or PET, whatever we're calling it, is estrogen, progesterone, and testosterone. A lot of the doctors who prescribe forget about the testosterone or aren't trained on it.
You had a good response to testosterone. Tell people what you felt when you said, because you had an immediate response.
So don't forget, I came to you, I didn't share with you all of the 5 doctors, but the first perimenopause appointment that I had was a really prestigious doctor in town who we won't name. And the doctor was like, I'm going to inject you with a testosterone pellet. Talk about like why I want to do this podcast. And she was like, it's going to change your life. Because I'm like, I'm tired. I'm like, yeah, I'm tired. Like I run a venture capital firm. I have 3 kids. We had a puppy at the time. And so I called Greg and I'm like, Greg, I'm going to get a testosterone pellet. Okay, I'll see you soon. And I'm a pretty bold person, but he was like, do not do that. Basically, for anyone who's listening, the testosterone pellet, Kelly talks about earning your pellet. I am a hyper absorber of testosterone. So Dr. Rubin, this is like half of what she normally prescribes. And I probably use about half of what's on the prescription.
And which is probably 1/1,000,000th of what your pellet was.
All right. So I'm going to go through the other 2 pieces and then just ask you a couple final questions and we'll wrap. But this one is so important. And Dr. Rubin actually had the guidelines changed. And I know how important the following medicine is for like UTIs, because I literally gave up. I had an appointment at One Medical, I think I told you, and like I gave it up because there was this little old lady in a wheelchair. Her husband was pushing her around a couple months ago, and they wouldn't give her an appointment because it was like 4 o'clock on a Friday. She had a cup of urine and like they didn't have any more appointments and they couldn't see her. It was so clear she had a UTI. And I gave her my appointment. And I think it's like the most love I've received in a look, like maybe in the past several years. But this vaginal estrogen is so important. And people have made comments about, I talk about it on my Instagram, but it's like you stick it in your vagina twice a week, and it's so helpful. And Dr. Rubin can talk about it for UTIs, for sexual health. But the part that sort of gets me, when you pick it up, it's 3 of these boxers. It does take a little getting used to walk out of the pharmacy with a massive box and be like, I'm here for my vaginal estrogen.
And yet it is the most important thing. There's 2 bad words on that box, the word vagina and the word estrogen, right? People have feelings about both of those things, and you put them together and people have a lot of feelings and they don't know how to write the prescription. But you're talking about a medicine here that is safe. It's like one of the safest medicines I could even think of, okay? There's very little harm that a vaginal hormone product, occasionally when you first start it, you get a yeast infection, just treat the yeast infection and keep going. But other than that, there is no harm that comes from this product. And yet it will prevent urinary tract infections. It will help urinary frequency, urinary urgency, irritation, burning, and itching of the vulva and vagina. It will help with pain with sex, dryness, arousal, and orgasm. So the reality is vaginal estrogen is Viagra. It is Viagra in every way, shape, and form. Viagra helps with sex and it helps with urination. And yet it also prevents UTIs, which could save our healthcare system. Not only would it save lives, but it would save our healthcare system billions of dollars. It's actually not even expensive anymore. It's well covered by insurance. A tube of vaginal estrogen cream is $13 on Mark Cuban's Cost Plus Drugs website, where you have your doctor send a prescription. So it's not expensive. It's easy to use. It's completely safe. It doesn't matter how much money you have or how educated you are or anything. If you're not using this, you can die of a urinary tract infection. I had a woman in my office just this week who's in her 80s, whose name is on buildings that you and I see every single day, who comes from lots and lots of money, who was dressed to the nines and looked beautiful, but she was gorked out of her mind from a urinary tract infection, and her vaginal pH was 7.5, and she was growing very aggressive and terrible proteus in her bladder, as well as other bacteria. And we had to give her a big shot of an antibiotic and as well as other antibiotics. And I had to shake this woman and say to her, I don't care how rich you are going to die if you don't use a vaginal hormone product. We got her, just like what your mom was just prescribed, a ring that sort of looks like my hair tie that goes in for 3 months at a time so she can go to her granddaughter's wedding, so that she can go on her bike trips, so that she can go and do the things she wants to do. She will die quickly of a urinary tract infection.
Well, this is probably like the most important part of this episode, because there's nothing controversial about it. You talked about this at the FDA, the Urological Society, which, if you could name it in a moment, changed guidelines in the past 6 months to talk about this.
This is why we have free prescriber's guide on our website. We've got free trainings on YouTube and on our website about how to treat genitourinary syndrome of menopause. The guidelines lay it out for you from the American Urologic Association. This is why I go to conferences. This is why I do courses. This is why if you ever see me on social media, I'm like a broken record. Even my brother and my dad and my husband can tell you how to prescribe vaginal estrogen, but this is what saves lives, right? This is what I spoke about at the FDA. My mother in the ICU, we couldn't get it because of all of these roadblocks that we had, and yet it is something that could have saved her life. It's really important that we talk about these vaginal hormones. That's a very simple tool that we use, and yours is a tablet insert, which is great. It's a generic product that's well covered by insurance. There are vaginal DHEA suppositories, there are rings, there are creams, there are different options that you can use. And it's not a one size fits all, so you got to find what works for you. I always say the one that you can use for the rest of your life is the one that you should use.
Yeah, because I remember when we first met, we talked about Intrarosa as an option. Okay, last one. This is someone asked about this actually after I saw you. I posted that Greg and I went with the pin. And so this is the Vulvar
Vestibule.
Yeah, okay. Cream, I can't even say that. But the thing that I think is made you so well known is you give women a mirror when they first come in. What was so eye-opening is you use this Q-tip to point out like where people's sensitivities are, but a lot of women can relate to, it's like suddenly I had 3 babies that were each over 8 pounds. So I'm like, I just assumed that was why maybe I had to step out of meetings more often to go to the bathroom. But this is like a game changer. I don't know if I really believed it when you first said it, but it's like, what do you want to say about this?
Okay, so if I could tell you that the outside of your cheek, if I gave you a jalapeno pepper and you rubbed it on the outside of your cheek, would feel different than if you rubbed it on the inside of your cheek. Do you agree with me? That the inside of your cheek in your mouth is very sensitive, delicate tissue compared to the skin on the outside of your cheek.
Right.
The reason I say that they're close together, but they're different kind of tissue. If you open up your labia minora, right inside your labia minora, surrounding the urethra, right before you go inside the vagina, is a very delicate piece of tissue called the vulvar vestibule. It's not the skin and it's not the vagina. It's actually a piece of bladder. And this piece of bladder is very sensitive to estrogen and testosterone. And this piece of bladder is called the vulvar vestibule. It is very sensitive to hormonal changes. So if you are lactating or breastfeeding, if you're on birth control pills, if you are menopausal or perimenopausal, you may have sensitivity or discomfort. Maybe tampons are painful. Maybe you can't do speculum exams. Maybe penetration is painful. And it's often due to a hormonal problem of a lacking of a little estrogen or a little testosterone. So all we do is liquefy a very minuscule, low dose, low concentration amount of estrogen and testosterone. And it's actually the only place I compound. Otherwise, I use FDA-approved products. And the reason I compound here is because I don't have an FDA-approved product. The closest thing we have is Intrarosa or vaginal DHEA, which helps a little bit with this problem, but you can't rub it directly on the tissue. So a liquid version would be lovely. But that's it. Those are the 5 treatments. And there's lots of options within those treatments. And again, we go on a long bit about all of these on that Peter Attia podcast that we did. And also the course, if you're a clinician who wants to prescribe or a clinician who wants to prescribe, we go into full detail in the course, which is really just wonderful.
Okay, wait, Rachel. So just last question, what is your wish over the next 5 years when it comes to women in midlife and you being someone who's fighting for our dignity, basically?
Yeah, for me, I want to train myself out of being interesting in this space. I want to advance the field of sexual medicine. I have no interest in being the face or the voice of anything. I want to advance the seriousness, the research, the education, the advocacy, and the mentorship within the field. That is my dream.
There's a whole history, and it almost doesn't matter how we got here, but there is a dark history here. So if you care about the women in your life, share this episode, listen. And to me, Dr. Rubin is so much more than a sexual medicine doctor, which is important, but I think it's so much more than that. And I just got to show you, she came to my surprise. I've never had a surprise party. And Rachel came, and that morning I had done a post about how I wished that we knew more for women at midlife. And she wrote me this card. I won't share what it is, but it basically said, here's something for someone with amazing vibes. And I just think you're cool because you just say it like it is. You are out there making changes, and I'm your biggest fan. So if you ever need anything, let me know. And just thank you for taking care of me.
Thank you for you, and you're just awesome. And thank you for having me on.
All right, that's a wrap on another incredible episode of Innovate and Elevate. Dr. Rachel Rubin, thank you so much for joining me and our viewers and listeners today. Your work is a gift to women and their families everywhere, and I am so grateful for your passion, your humility, and your brilliance. What I hope you take away from our conversation today is this. Your symptoms are not in your head. Your symptoms are real, and there is hope. There are doctors like Dr. Rachel Rubin and other well-meaning doctors. Doctors are well-meaning, and we are rewriting the script together of what it means to be in midlife as a woman. And as Dr. Rachel Rubin said, we deserve to age with dignity and power. Thank you for tuning in. If you know a woman or someone in a woman's life who can help her hear this information, please share it. When women are healthier, families thrive. Here's to a better second half and to better health for everybody.